Good evening. Welcome to the final session of our health policy course on topics of interest and concern. I'm Stephen Linder with the Texas Medical Center Health Policy Institute as the Associate Director, and to my left, Dr. Tim Garson, who's the Director of the Health Policy Institute. We have planned a session with a different format tonight than in prior sessions. In place of a panel and a moderator, we intend to facilitate a discussion with you, the audience. And as part of the facilitation, we'll rely on the pollev.com. So if you can get your phones ready to participate and to log in, we'll go through a series of questions that you'll respond to, and then we'll spend some time going through your responses and have you illuminate and discuss features of your responses. And we'll try and spread around the opportunities to speak so that we hear from many of you we haven't heard from before as the night proceeds. You've probably noticed that there's food out there, and so if you haven't already got some, you're certainly welcome to partake either now or during the session. If your energy flags, go out there and refresh and come back. And I think we've got some interesting things to talk with you about. Now, the topic for tonight is national health care reform. And we've noticed a pattern in the nature of reforms that have been proposed, that many of them, at least the ones that are global in intent, that are not just incremental adjustments, but rather wholesale kinds of reforms, we've noticed that many of them rely fairly heavily on existing public programs and do some things with those public programs, modifying them in certain ways. And part of what we're going to talk about is the nature of these modifications. So what I'd like to do is begin by asking some general questions about how people perceive the programs that rely heavily on the public sector as a template for reform, as an avenue for making adjustments in the current array of policy programs. And we'll discuss at some point before we're finished some of the more incremental adjustments that have been proposed. But for now, I'd like to focus on the larger, more impactful reforms, at least in their intent. So let's look at the first slide, and you'll see, on the whole, is public insurance superior to private insurance? And you'll notice there's a yes and a no response. And when you've had a chance to reply, we're going to ask you in sequence, that is, taking the yeses first, why you think that. So as you reply, be thinking about why, because you're going to be asked to account with a why response on the very next slide. First, we'll do the yeses, and then we'll do the no's. But for now, let's everyone register your response to this question. Do we know when we're near complete? That's cut off of my screen, so I'll rely on you to give us a cue when it's time to move on. Dr. Garson, any initial comments, orientation, warnings, anything?
Have fun. Well, you know what's going to happen is somebody is going to hold their hand up and say, "What do you mean superior?" Right? So,
Do you want me to say that?
so fairly soon you may want to, as you were answering, you may want to sort of say, "What did you mean when you meant superior?" Or not.
We're good? All right. So, next. If you answered yes, tell us why. And this, of course, reflects your construction of what superior meant on the last slide. Your responses will begin to appear. You can, of course, copy other people's responses or fashion your own, whatever you would like. The only thing we prefer you not to do is to stay on the sidelines. So register your response, please. Better payment is big.
Or unitary. Better everywhere.
Very nice. We have some momentum now, picking up.
Guys must have been drunk when they figured out how to put this together.
I know, it's really great fun. Because the frequency of response is both the relative size and the relative position. And it registers it simultaneously, right?
Yes.
Are we close? All right. Before we go on, we need a few volunteers to give us a fuller account of why it is everyone is at the middle and any interpretation of some of the more marginal responses. So,
am I right that this thing can then get displayed where you actually can read it?
like in a list of
Yeah.
rank-ordered
Yeah, I
items?
thought there was. Ryan, is that true?
Not the way it's set up currently.
Uh,
I would move on and just discuss it because it's set up as a word cloud right now.
This is the more entertaining version, you see.
Okay.
Yes.
Well, then just
We've left
shout it
analytics
out.
at the door. Yes.
Got it. Well, then shout it out.
Someone who responded, everyone, please tell us what that means to you. Yes, please.
I'm just finally on Medicare, and to me it means I can't lose it. And I don't have to change every year and find new doctors. It's fairly comprehensive. It's fairly easy to navigate. Also, I lived in France for 5 years and found their system really great, very easy to use. Everything was covered. Doctors even came to my apartment, so those are my reasons.
So what was different between the French public system and Medicaid?
Well, this is many years ago, but literally, you got your card, I guess. It's like it's been 40 years. But once you got your card, you would just go to any hospital. You'd see, I had a problem. I saw experts. I never paid anything.
That's theoretically true here for Medicare as well, right?
Yeah, except for you have Part B, of course, that you had to pay for. But I just found it super easy. You just never deal with anything. They do all the billing for you. So.
More. Who said the public system is better, and when we said, better, what's better? What did you mean by that? Come on, there's a bunch of you up there.
There's a lot of cues here to follow. Just read them off. Tell us what you think. Why is public insurance superior to private insurance? You've endorsed that concept. Why? Follow the cues, tell us.
Oh, come on, let's see. All right, what does it say here? So everyone's covered, I guess. Lose people must be. Wonder what lose people means. Maybe it's part of something else.
I'm not sure. French is there as well.
Huh. Anyway, yeah.
I think one of the reasons that a public healthcare system is better is that it doesn't have shareholders who are profit-driven.
So here's a question for you folks, and that is that the hospitals of today sort of come in a couple of different flavors, but the big flavors are not-for-profit, as in Methodist, and for-profit, as in HCA. What's different? Why would one, because there ain't no shareholders at Methodist either, right?
Yes, I approach the question from the payer perspective as to government insurance versus private insurance. But if it's system-wide, then yeah, your question about provider remains. But just because it's a non-for-profit provider doesn't mean that they're not trying to make a profit. It just means
That's
that they
for sure.
have control, not controls, they have, they are required to give non-for-profit services or services for free. And then that's still a very gray area as to the percentage of that.
Somebody, I'll bet Stephen knows. I mean, I am not, and stupid me, Ryan and I just finished a book. I don't think we dealt with the difference between outcomes in for-profit and not-for-profit hospitals. As a matter of fact, I know we didn't. We probably should have or could have, we just didn't. Anybody know about that? Do you get better care, worse care, more expensive?
I only know about nursing homes, as it turns out, because I ended up doing a literature review of sort of a comparative assessment of those two different structures across the U.S., surveying most of the literature that gave an account of metrics and a direct comparison between the two. And as it turns out, as you might expect, if you favor public systems, that in fact the publicly owned nursing homes perform better than the privately owned ones did. And we heard from 20 different nursing associations after the publication of that piece, but it wasn't our original research. We had just done the lit review on the research and summarized it. No comparable pieces I know about doing for-profit and nonprofit providers, especially tertiary care hospitals as opposed to freestanding emergency rooms or something like that.
Well, you know what you'd think, and then we probably should move back to systems, right? Because that's really what this is about. You would think that the tendency in a for-profit kind of hospital would be you would do more stuff and you would react more to the things that get paid more. Not that that's unknown in other hospitals, but one might think that per 100 patient days you might have more MRIs, you might have more back surgeries, I don't know. You would think that, I just don't know if it's true.
In the nursing home case, the staffing patterns were different between the two. And so the profit making didn't necessarily generate more procedures, but they were more likely to have skeleton crews on, meeting the minimal requirements, and that was how they cut costs.
So, but
In the for-profit, yeah.
But so here, we're really talking about Medicare versus Aetna, right? I mean, that's this question, right?
Medicaid too, right?
Yeah. To me, I'm either one. I think probably Medicaid has so many other dealios with it that it may be a little easier to just think, because you don't hear a lot of people talking about Medicaid for all.
Although we have that as one of the plans.
But kick around for a minute, if you would. A third of you or so said that essentially public is better. Yeah, go ahead.
So suppose in terms of this question, I responded yes because it standardizes a system. So in terms of like a governmental type regulation, you have things to regulate costs, you have things to regulate reimbursements, you have things to regulate abilities in care and things like that. So if you go to, again, if we're saying Methodist first, well, that's not the best example, but let's say you get reimbursed again for procedures, you may end up getting more of those procedures than less, just depending on what you actually need versus don't need.
What about from the patient's perspective? I mean, we heard about being on Medicare and having things covered, and if you're anticipating being on Medicare and not yet, and you have employer-based insurance, and you compare your coverage to your older friends who are indeed already on Medicare, how does that comparison stand up? Are you looking forward to being on Medicare? From the comprehensiveness, from the cost savings, from a variety of different features that Medicare offers? Or are you really happy with your insurance and not looking forward to the day when, as you retire, you gain access to Medicare exclusively?
I don't think the answer is very easy. First of all, when you think about Medicare, it's no longer state Medicare. It's Medicare managed care. There's any number of iterations of the public financing system for health care anymore. So it's not an easy question. But what you do get is, in general, a more stable financial environment from the patient standpoint, generally with a greater opportunity to make sure that they can access the physicians and the facilities that they're interested in general. There's some exceptions, particularly with the managed care pieces. With a public or with a privately financed plan in business, whether it's employer-based or not, because people have, or organizations tend to switch those every 3 to 5 years because of the changes in the plans, the Blue Cross Plus, the Blue Cross Plus Shield Plus, all the different iterations, and depending on what day and what afternoon and how a person stands, whether or not their physician is in that network or their testing facilities in that network, it's very difficult, I think, for the patient in a privately financed network as we've defined it to navigate easily.
And just as you get to know it, after 3 years, it's gone. And then you're in a brand new system with a different network, with different rules.
It's also difficult not only for the patient, but the care providers, the physicians, the social workers, the nurses, everyone who's touching that patient with the insurance companies, because it's going to vary from insurance company to plan to diagnosis to the hospital that patient is in, and there are just a lot of energy gets expended dealing with that as opposed to actually caring for the patient.
So how many of you, I'm assuming this is a HIPAA compliant question, but if it's not, somebody will tell me it isn't. It's only HIPAA non-compliant if you answer. have had to switch networks by virtue of your employer, either your employer, you stayed in the same employment and the employer changed, or you changed in employment? Okay. Now, of you that changed, were you able, raise your hand if you were able to keep the same GP, the same primary care doc? Could you keep the same primary care doc? Yes. Could you not keep the same primary care doc? No. Looks like about 10 to 1. If you had a specialist, could you keep the same, I'm guessing it's the same, could you keep the same specialist? Yes. Could you keep the same specialist? No. Huh. Okay. Now, pressed me on leading somewhere. How many, well, I'm going to make an assumption. How many of you are new enough to Houston that you had to pick a primary care doc when you got here? Not that you've had forever, but that you had to. How many of you did not? As in, you've been here for a long time and it's been forever. Okay, well, that's really interesting. Okay. Mm-hmm. So those of you that picked, and then here's where I'm going is, does it really bother people? Everybody says they want to choose their doc. But most of you who moved plans or moved employers, you had to change your doc. Was that a problem? And what, I know theoretically what it is, but.
So we went from Health Select, because we didn't change employment, but we went from Health Select, coming from United to Blue Cross, and we were not allowed to keep our PCP. But we complained, and the PCP complained, and so they grandfathered us in if we had already been in the system. So we had to have somebody in between, and then we ended up going back to our original PCP if we wanted to. And so what it did was you just didn't even go anywhere or seek any services during that almost a year's worth of time. And fortunately, you didn't have an emergency.
I'm interested, and I guess this is more a statement and we should move on. If the PCP average visit is 8 minutes, what kind of relationship do you create in an 8-minute doctor visit, and therefore does it make one hill of beans of difference who that person is?
I feel like you're right, you could keep trying to find someone you finally like, but I was a little worried about like them getting my tests. Like, I haven't really done that with Medicare. They're going to have to, I haven't dealt with that yet because I just started. Like, when I have a mammogram now, Kelsey-Seybold, are they going to be able to get my mammogram from Baylor, that type of thing. So that's, to me, maybe the most important thing is switching your records from one to the other.
Just what you said is the reason that people who don't want to change, that may be part of the reason they don't want to change. I spend more than 8 minutes when I see my provider. And
9?
No, I spend enough time. I mean, it depends on what the problem is. But because of that makes me, I was part of this same system and really just kind of held out and hoped for the best that we wouldn't have to change. So.
I've ended up utilizing an advanced practice nurse, and it's worked far better because they spend the time and they get to know you far better than the physician who was running in and out the door.
Sure, more.
Let's switch to the next one.
I have one more comment on the keeping the PCP though. As you mentioned with the nurses, it's not just your PCP that you're used to seeing when you go to your PCP. You're used to seeing the same nurses. So even if you only get 8 minutes with your actual doctor, you have the same nurses who know you are. They know your history. So it's more than just your PCP that you want to keep when you have to switch. So it's, yeah, you might only spend 8 minutes with the doctor, but it's the same nurse who saw you the previous time. And it's not always the same nurse, but if you go to the same doctor, they get to know you too. So it's kind of more than just the sole doctor that's important.
It's the relationship.
Yeah.
Office staff matters a lot
Yeah.
to the quality of your experience. Sure.
There are only 2 abstracts that I ever wrote that I didn't write up. And this one seems so stupid not to have written up, but I took clinic patients and measured, these are return clinic patients, whether they saw the last doctor that they saw again or they saw a new doctor. These were people with ongoing chronic disease. And we measured how long the visit was and what tests they got. You'd think that would be a sort of a neat thing to know. Well, it turns out, as you're saying, the data backed it up, which is that the time was bimodal if you knew the doc. It was either 3 minutes or 30 minutes. You sat around and shot the breeze, or you went, "You're fine, thank you." Direct relationship, though, with tests. If you didn't know the patient, you didn't know the doc, they got bunches more tests. So it would seem just more efficient to keep the same doc. And I know there are these assumptions about, in-network and out-of-network, and you got to keep this, the docs in the network. I'm not sure there's a lot of data about my network is cheaper than your network. I'm not sure that makes one hill of beans different either, other than restricting people. I'm not sure that, my narrow network is cheaper, but anyway, more.
Yeah, part of the employer's bargaining across insurance providers or managers of their funds is going to be based on how large the network is. And you assume that for an employer of a certain size, they can purchase a network of a certain size. But if you change employers, you're likely to then have your network either expand or contract based on the employer's ability to bargain and have some leverage over those things. Now, having heard a lot of stories about why it is private insurance is unsatisfactory, we're about to look at the reasons why private insurance is superior to public insurance. And here's the reasons. Let us know when we're close. We're good now? All right. A lot of choice and market and better and choosing and quality and options and freedom. All right. Let's hear from you. Those who believe that private insurance is superior to public insurance. And not necessarily the provision itself of care, although we talked about profit, nonprofit a little bit. We're not talking about the difference between going to the VA and going to Methodist. We're really trying to get at the payor issue, which a lot of the reform is directed at.
Okay, while you're thinking, I want to delve one more time in terms of, and the word relationship is, I guess everybody uses it. I'm about to say, do you have a relationship with your PCP or their nurse or their nurse practitioner? And I guess I'm not even sure what relationship means anymore. So everybody says, oh, do you have a relationship with? But I'm not sure what that means. Would you define that by, they know my dog's name? No. But I guess, some degree of comfort that they know who you are and you know who they are. So using whatever definition you'd like to use, how many of you feel that you do have a relationship with your PCP? Or your PC whatever, your PCP provider, whether she or he be a nurse or a doc or whatever. So how many yes? How many no? About 50-50, I think. Okay, specialist, how many yes? How many no? How many are asleep already? Okay, for those of you that didn't turn around, it's about, seems like it's about 50-50. Okay, thanks.
Good.
Somebody,
I was going to
Yes.
answer your question about the public versus private. I
Sure.
think one of the things that is unique to, say, the public is in Medicare, the deductibles are so high, the 20% copays, and not necessarily the deductible, but the copays, I'm using the wrong terminology, is that most people are so worried about that, they feel compelled to buy a second policy to cover that. So I have never, in my personal experience, had to do that with my private insurance, because usually it's got very reasonable deductibles and copays and all of those. And I think that's probably changing now as policies have evolved and you hear about people with incredibly high deductibles. But in reading about that, I don't remember reading anything about people going out and buying second policies to cover that.
Yes.
I don't know much about it, but I just know that I was paying $800 a month before I got on because I quit my job. And now I'm paying like $250 a month for that second part. So it's still a lot cheaper even though you have to buy a supplemental. That's my experience.
One of the most common forms of gap insurance in the private market is Aflac. So anybody that has Aflac, I mean, that's for cancer and other programs. So it's very prevalent out there and incredibly profitable for Aflac. But there's a huge market on secondary when you have private coverage like that.
So it's not just the Medigap insurance covering a variety of out-of-pocket.
There's Aflac and there's several other ones that are either specific to cancer or other programs that are out there. And so it is quite popular in the private market.
they just insured ducks.
One of the things that I've seen with private coverage is that there tends to be, I think, more innovation, and you don't see people trying to manage global budgets. If you talk to people in Europe, they'll tell you that their fear is, and that they've seen some stifling of research and innovation, because what happens is every time there's a budget crisis in Europe or in the EU, they just cut down on budgets. And so there's a lack of innovation, a lack of ability to get new products into the hospitals and programs because they don't want to increase what they think their incremental costs will be. So it does have a tendency to stifle innovation if it's not done correctly.
You know, we probably don't want to spend a year and a half on this, but the only reason I'm commenting on it is Ryan and I have a little bit in this on a chapter. And it's tough to follow the bouncing ball when the pharmaceutical companies say you have to pay us these exorbitant amounts or our innovation will suffer. Seems like there is a brown flag that one might raise, because following the money that says they could probably make less innovation if they wanted to, but it seems, at least to me, that their budgets are so intertwined and so difficult to follow that you either have to believe them or not believe them when they say, well, you know, we have to be on the Fortune 50 because that's gonna make us not innovative. I don't remember, maybe Stephen does, you know, what percentage of the innovation in the current pharma is really done in-house pharma anyway.
As opposed to by NIH-funded third parties.
Yeah. So I think, to me, that's John, I know you're right, and I know it's right to say, but boy, that's tough to prove. Or, I mean, it's certainly, you hear it a lot, right? Pfizer, whatever, stands up, you know, we've got to charge $75,000 for an aspirin because our innovation's going to get stifled. But boy, show me the money.
I've spent part of the past 4 years, working with private companies in Italy trying to bring products to the United States because they're having trouble getting them within the procurement cycles of those hospitals that are continually cutting their budgets. So they're saying that if we can get it to the United States, we have a chance to get it to a distributor, to get it to a purchasing organization that'll get it inside a hospital if a physician champions it. But in the EU, there's not that power. What's happening to them is they're saying, look, we're using this right now, it's working, we budgeted this, we have this inventory, we're not going to change those things. That's with medical equipment and other things. It may not be pharmaceuticals, but with pharmaceuticals, you've got global budget caps in most of the countries that have global budgets and are publicly financing their healthcare system. And so, what pharma's been able to do is very effectively lobby to make sure that Medicare doesn't negotiate prices in pharmacy, and to make sure that those things happen. So we get bubbled up and kills us in pricing.
Mm-hmm. Relatedly, it's unclear the extent to which private insurers offering a package of benefits are innovating as opposed to following the CMS lead. And where the innovation comes may well be in the CMS experimentation on Medicare populations, in devising cost containment programs and ways to save money and deal with other problems in the program. And then the private insurers generally follow suit. They'll cover something that CMS finally decides the evidence is sufficient to cover, that it'll make a difference in the long term in terms of the overall cost to cover these things now, and the private insurers queue up for it. And what happens when the benefit managers switch from one policy to another policy is a bit of marketing in terms of the combination of things, and maybe some internal wellness kinds of features, some whistles and bells have been added to the program to make it more marketable relative to one's competitor, or the competitors decided to raise rates because things are turning south for them as a company, and then they bail and go to another company. An interesting example is what happens when you have an entity, a large corporate entity, who's self-insured. And so all they're doing is hiring a manager to process administrative claims and make sure there's no corruption in the system. But basically it's self-funded, and they decide what they're going to fund internally because they control the fund. And those of you associated with the University of Texas benefit from having a fund that's administered by the university. And so they can change their reimbursement rates, they can change their rules, and they dictate to now Blue Cross Blue Shield what they're going to be charging, what the pattern of benefits is going to be. And it's a position of advantage enjoyed by the largest companies when you have employer-based insurance, that they can indeed choose to self-insure, and there are lots of benefits to them tax-wise for self-insuring. And that's another avenue that you don't hear much about.
My first comment was from a while back, and it was that I wonder about, based on an N of 2 or 3, I have family and friends in Australia and in France. And I know that they have both, they have the system, the public system, but they often have private insurance as well. And then my second question that just popped up is, are we the only entity that has employer-based insurance? I know that Australia does not. I don't know about France, and I don't know about the rest of the world.
Germany is all employer-based.
Okay. So we're not, are we more unusual, or is it like?
don't know because I've got I don't, only in that employer-based has a sort of a meaning here that in Germany they pay for it. But I'm not sure that they choose it I just don't know whether they choose it to the extent that our self-funded plans do.
The big difference is universal coverage by and large. And we're relatively isolated in not having a comprehensive single safety net.
Somebody must have said that.
Hi, I have a comment about innovation and kind of relating to this single safety net. So, sir in the blue, you mentioned that there's these people in Italy that have these new devices that they developed and trying to get in the companies. However, they as individuals probably don't work for large companies providing for their insurance. And so what I've seen here with my friends in the startup world, they don't have their young people. They sometimes are still on their parents' insurance, often aren't. But if they try to be innovative and try to start their own companies and they have a major medical emergency, it's a big problem. Like my deductible is $7,500. So that's a big problem for young people. So I think that the innovation is really dependent on us having this universal safety net that allows people to take risks. And you can have innovative companies and startups if you have these people have these kind of safety nets, as you said. And the fact that these people in Italy have these cool devices and can't get them into the hospitals is a shame. And I think there should be a way to fix that. But the innovation for the insurance companies, I don't think it's very innovative the way it is right now, because it's not allowing for new innovations in just general technology.
We ready to move on to the next? Here's a busy slide that has 10 of the major healthcare proposals. Again, at the start, I said we'd emphasize those that were global in scope. And you'll see they form a hierarchy across the proposals that have taken the form of bills in our US Congress. And there are those that rely on Medicare and do things to supplement or to alter the reach of Medicare, the coverage requirements, who gets covered, how they get covered, what it costs in their coverage. Then there are ones that take a step back and say, well, we don't necessarily want Medicare for all. We just want Medicare for more than just 65. So when you turn 50, you can buy in to Medicare in lieu of private insurance, especially if you don't have employer-based insurance. You can then purchase a Medicare-like policy through an ACA market. Most of these plans rely on the ACA, except those at the very top who are in favor of Medicare for all, because there's no need then to have a market, because everyone is covered by the same plan. So the ACA gets engaged about the middle, and as you move down, you have increasingly smaller and smaller groups of eligibles who are able to move on to a Medicare-like program. Till the one at the very bottom, you actually can be eligible for Medicaid under certain circumstances, and a supplement is offered, especially in states where there is no Medicaid expansion to cover people below about $300% of the federal poverty level. And so we've got this emphasis on federal templates as the way of reforming our health care. And there appears to be a dichotomy between the plans that are more piecemeal, that rely on the existence of the Affordable Care Act and its markets, versus those that want to do away with those markets and rely exclusively on Medicare itself. And there's also difference of opinion about the role of private insurance. With Medicare for All, we see private insurance going away. And with the other plans that are more incremental, again, providing new options in the exchange marketplace, we have a variety of different ways of adjusting what's available and of subsidizing it differentially that expands the way these markets work and that bolsters the ACA in ways that have been advocated since it was first implemented in 2014. So we're going to ask some questions now around these plans and to get your responses, and then more importantly to draw you into a discussion of some of the features that are part of these federally based plans. So, do you support automatic enrollment in universal coverage?
Okay, we're done.
we can go home now.
We're done.
You'll remember from the prior slide that not all of the plans that are proposed support universal coverage. And that by and large, the only plans that support universal coverage are those that do away with private insurance. And there appears to be a trade-off. Private insurance, not universal coverage. Do away with private insurance, get universal coverage. There doesn't appear to be a plan that straddles, permitting you to have universal coverage and private insurance as well.
Mine.
Tim's plan is. There you are.
But this question is asking if universal coverage exists, is enrollment automatic? In that world, should enrollment be automatic? Can you kind of clarify the parameters of the question?
What would you like them to be? So one is whether or not you've decided that universal coverage is an essential ingredient of any plan. And relatedly then, do you support automatic enrollment to promote universal coverage? Well, I support automatic enrollment because I'm in favor of universal coverage. Or, no, I don't support automatic enrollment even though I'm in favor of universal coverage, but I have other ways of getting us to universal coverage that I'm happy to talk about. So there it is. An imperfect question leading to a perfect discussion. Oh, don't pass the mic. Wait. No. Please. How would you respond? And did you say yes or no?
So I'm deferring your question of universal coverage or not, and I'm assuming that we're in the environment of universal coverage. I think for universal coverage to work as effectively as you would like it to, automatic enrollment is necessitated. I think that you can have universal coverage without requiring automatic enrollment. And I think that's the interesting facet
What
of
if we
this.
took it apart? How many of you are in favor of everybody having coverage, no matter what you call it? Okay, how many of you are not? Okay.
I have friends. I know people who have opted to not take coverage because it is in their best interest. You spoke about having a $7,500 deductible. I have friends who have opted to not have insurance and have paid out of pocket and been much better off not being covered.
Let's raise the bar or lower the bar and say, ignore the word deductible. Should everybody have health care coverage?
Should you require it?
No, not what I asked. Should everybody have it?
Sure.
Okay. Then the question is, when you say, and I have a real bias, everybody wants to know if healthcare is a right. That to me is a moronic. You can spend 3 hours talking about the definition of the word right. So that doesn't help me. That's why you can get around it and say, should everybody have healthcare coverage? Great. Don't worry about what to call it. Yep, everybody should have it. Now, we're going to get in Stephen's questions in a minute to some details on that. But if you say everybody should have it, then the question is, how do you get there? Do you require everyone to have it? And if you don't, I guess part of the question is, what are you getting on the other end? It's one thing if you had absolutely a single safety net and everybody paid taxes, and the only reason to require or to have automatic enrollment is for the accounting part of it, just so that you could find people, because it wasn't going to cost you any more or less because you already paid your taxes. So in that instance where you've got a system that is truly a safety net, requiring it is sort of meaningless. It's not like the individual mandate. It's like somehow whether you have automatic enrollment or, you know, it's hard when you think about it. You know, I'm one of those guys that at the beginning said that, well, of course you have to have a penalty for non-enrollment because you got to make the people, you got to make the healthy people sign up. And when you really think about that, that's moronic. If you could afford it, everybody wants to have health insurance. So what you do with the individual mandate is you make people pay for something they're not going to buy, which is really stupid. So having said that, I guess the question then is, if you're going to have health care for everybody, it probably doesn't matter whether you have automatic enrollment or whatever. Is that fair? Mm-hmm. Okay, keep going. You're on.
Okay. Anyone want to add anything to this piece? Sure.
I'm one of the with one of the companies in the TMC accelerator, and I used to live in many European countries, and probably the best healthcare system is in Switzerland, which has the resources and innovation of America, and at the same time they do have universal coverage. And I think the way they ensure it is that you have to choose. Everybody has to choose a private insurance company, and they also have competing hospitals, but you have to have health insurance. I don't know, you probably go to jail if you don't. And of course, unemployed people, I think for them state pays instead, but you have to choose a private health insurance company. And I think it actually produces a good result because nobody is left behind. And at the same time, there is in a way, element of competition between the payers and providers.
Mm-hmm. How do they deal with non-Swiss citizens who are residing in the country? Are they covered as well, or
Yeah, it's exactly the same. I mean, it's you have to have a health insurance to be in the country, and so I think if you are unemployed, they're probably gonna deport you after a while.
Yes.
They're not that friendly to I think they're friendly to the high qualified immigrants, and I think they're quite brutal with the less fortunate ones.
Yes. Back there, please.
I want to go back to the chicken and the egg of automatic enrollment or universal coverage. I think you could make the case that the most recent effort in Obamacare, whether it was through the individual mandate or the marketplaces, created an environment of automatic enrollment, but it didn't lead to universal coverage. So, are we just going to say the fault is because the Supreme Court didn't mandate Medicare expansion? Or, I guess, if we think that automatic enrollment leads to universal coverage, why aren't we there? Why didn't it result in that? Or do you have to have universal coverage and then automatic enrollment comes in later? I guess you've got them paired here, but I still see them separated. And again, I think you can have universal coverage without automatic enrollment.
So you've made the argument that there's automatic enrollment that didn't lead to universal coverage.
Correct.
In part, I would suspect that it's different than Switzerland in terms of the enforcement, where the fines were less than the cost of the insurance. And so people chose to pay the fines rather than buy the insurance because it was trying to preserve the private system where a few insurers would be present in the market, and the premiums weren't subsidized sufficient to make the policies affordable. And so you didn't get everyone as a result of the automatic enrollment. It wasn't automatic. It was your experience of being compelled, and how did that play out? Usually it played out badly.
So do you think that if the fines were higher, it would have been a better outcome?
Well, automatic enrollment is an interesting challenge, and the question is, how do you do it automatically? We do a lot of things automatically, and I expect that there are a variety of mechanisms whereby enrollments could have been done in a less manifest, less painful way that would have been automatic in smaller, invisible kinds of payments.
We got 30 minutes.
In other schemes.
More.
So.
Next. Now we're going to get in the weeds with this, guys. Keep going.
Did you change? Yes. Now, this is about employer-based coverage. We've spoken about this just a bit, but you'll notice that in each of the cases of the Medicare for All variations, they do away with employer-based insurance and the entire scheme of employer-based insurance. In fact, they do away with the private insurance market altogether, which makes it difficult to pay, to find private insurance, and impossible to have it in this country if you're covered by Medicare for All.
I can't remember, is there one behind this that says private coverage at all? Is this specifically about employer-based, or is this really about private coverage?
I don't recall. It's employer-based, so there is no single standalone private coverage, eliminating private coverage. That's only the first question where we talked about the difference between public and private.
So you don't have a next slide about whether you get rid of, I thought there was one where you just get rid of private coverage no matter whether it was employer-based or not, or you don't have that? Okay.
No?
Anyway, sorry.
Okay, I didn't remember that one.
So there's really two questions here, right? Mm-hmm. There's private coverage, yes, no, and there's employer-based, yes, no. Mm-hmm. Obviously, if no to private coverage, then employer-based is no, but you could have one without the other. Mm-hmm. Meaning I get to buy my own private coverage.
Then you lose the employer's subsidy and you're on your own.
Well, anyway, you keep going.
Okay, so we have some yeses for support ending employer-based coverage. Can we have some reasons offered, some whys for the yeses in that case? Because this is a substantial departure from the tradition that's been around since the 1930s? Yes.
I think the system we have, as one of the other speakers alluded to, can create job lock. It can stifle people from becoming entrepreneurs or doing, sort of creative things. I also think it's interesting that a lot of the people who are sort of supportive of the status quo, I want the freedom to choose my plan. I don't want the government taking away my employer-based coverage. At the same time, they've simultaneously sort of deferred major decisions about their health care to some sort of anonymous benefits administrator within their company. So I think, I'd probably, I don't necessarily feel comfortable having such important decisions about my health and my insurance and my family's health sort of punted to my employer.
Others feel similarly or have a different reason for wanting employer-based coverage to go away.
I think when you look at the reading, it's a serendipitous occurrence. I don't know that when it started, way back whenever it started, that they ever envisioned it would be what it is today. So for the reasons he stated, I think it does lead to a lot of job lock. People are not able to access a system to get insurance often outside their employer. It can cause a lot of problems for employers trying to provide the benefits. So for a lot of reasons, it's a problematic way for people to get their insurance. Now, what the alternative would be, I didn't answer it getting into those weeds. I just think because it is the status quo, I think we're afraid to let it go, and there's a lot of problems associated with it. So that's why I answered it should go.
So if, hypothetically, assume that the employer current contribution can be trapped, that's really important, right? Because if the employer has to pay nothing, the system falls apart. So let's assume somehow there is something that the employer has to sort of
A trust fund.
Continue to
Set
pay.
up, yes.
Okay. How many of you would be in favor of non-employer based, but there's a public system that's for everybody, but you can buy your own private insurance? So how many of you would be in favor of having your own private insurance in addition, or the ability to get private insurance? Okay, how many are against the ability to get private insurance? Okay, so no one, which is interesting because all 5 of those first ones, the Bernie and the next ones down, all get rid of private insurance. And that, to me, and I gather to everybody else in the room, is right up there with moronic, starting with the fact that the insurance companies are pretty powerful lobbyists. And if you really, in this country, think you're going to close down private insurance, I don't know how that works. So anyway.
Let's do the next one.
Oh, there you go. Oh, okay. Yeah, there it is. Okay, that's the one we just asked. Right?
Yes.
Yeah, okay. There it is.
100%.
Okay, I thought there was. Yeah, okay.
Next one.
Next one, there we go.
So this is looking for public financing of the system, again, going back to the original question about public and private, and whether one's superior to another. And this is trying to get at some of the reasons when you have a system that's financed by taxes. And if we took that employer contribution and put it in a large fund, most of the Medicare-based reforms create a fund of some sort and generally put a lot of money in the fund, ranging from $1 to $5 billion to start out to ensure universal coverage. So for those of you who want to eliminate premiums and have the system financed by taxes, why is that? We're favoring the minority responses here. Yes?
I just think it's more equitable to do it that way, to get everybody covered, and I just think it's really a crime that people are not covered in this country.
Mm-hmm.
Yeah.
And a tax-based system that provide the coverage.
So would you have, what kind of tax would you have?
We have a Social Security tax and Medicare. I mean, we already have deductions right now, not paycheck.
No, it wasn't quite as stupid a question as it sounded. There are a bunch of different ways and a bunch of different rates that one could choose. Do you do it by the progressive income tax? Do you make the tax like a current premium, but it's called a tax? How would you do that?
Go after the 1%ers, is that it? They can provide universal coverage. Yeah. So for those of you who said yes, eliminate the premiums. We'll do it by taxes. Any idea what kind of tax?
Yeah, that's
would
what
work here. Yeah.
I've never thought of that. You know, oh, tax. Well, okay. What kind of tax? And is it really just a premium with lipstick on it, or something? I've never heard. I mean, somebody must have written about this. I've never actually seen people. You know, I'm sure it exists. You know, people overseas talk about 5% of income going to healthcare in their taxes, but I don't know if that's true. A funny story, and then we can hear from John. So I was in Costa Rica 15 years ago, and a cab driver was driving me in from the airport, and I said, so, you know, how do you got, you know, you got healthcare? Yeah. How do you pay for it? Oh, we have taxes. Oh, really? How much? 5% of our income. Really? Well, you know, that's true in a lot of places. I said, but, you know, for good grief, if you make $200,000 a year, is it really 5% of that? He said, yes, it is. And I said, well, how does that work? He said, everybody lies about their income. I said, oh, okay. So, okay, got that. Oh.
A per capita tax would be regressive in nature. And I don't think that that would pass the smell test here. I think it would have to be a percentage of income tax similar to what you see with Medicare. I mean, we've made this decision back in the 1960s that to finance health care for people at a certain age and above, that we would all agree to invest a proportion of our income, which is consistent up to a cap, and then later on the cap's, you know, been adjusted and eventually removed. So I think that that's consistent with how we thought about financing health care, and I think probably the most equitable way to do it. And yeah, I'm sure people would end up lying about their income, you're right.
About their income now anyway.
Not in the United States? No, that was only Costa Rica.
That's if you can see tax returns. But I recently asked a cab driver in another country the same question. And they paid a high percentage, I don't know the exact number, of their income. But they got education and they got health care, and they had a different mentality about taking care of their fellow human beings and about what they were getting. And if we could relieve people from the amount of paperwork that shows up and emails that show up and arguments with the assorted different insurance companies or what have you, you know, I think that it would make the world a lot easier and a lot cleaner and efficient ultimately.
Yeah, I just want to my previous example, so they have the opposite in Switzerland. It's called a premium, but it's effectively a tax because it's so heavily regulated and standardized. Well, the basic coverage which the different companies offer, that it's a tax, what they call it, a premium. Mm-hmm. But it's very regulated, so I think in the US you may not, people may not like it here.
Mm-hmm.
Yeah, Ryan's been trying to talk for a year here.
Well, I think this is a more important question than it might initially seem, because there's a lot of PR and sort of optics that go into this. And if you can eliminate a lot of people's premiums or eliminate a company, you know, the premium, part of the premium that a company pays, and replace it with a tax, that's a net neutral for the consumer. And I've got a feeling a lot of people would go ballistic if all of a sudden you said their taxes were going up and they didn't have to pay their premiums because they can't wrap their heads around it. In a different life, I was a journalist and I wrote about infrastructure, and there was a big problem, and that was that cities and states didn't have money to pay for highways anymore. And said, don't worry, we figured out how to fix our highways, and we don't have to raise your taxes by a penny. And that was toll roads. And it's the exact same product, paid for by the exact same people. And the only difference is the private sector had to get a little bit of a cut of it because you had to do the funding, have it passed through the private entity. So I guess that this is kind of a roundabout way of saying I do support this with the caveat that some smart political marketing people in DC would have to be pretty clever about how to sell this because I don't think that the average voter can sort of wrap their head around the fact that this could be actually a pretty good trade-off for them.
So you have a toll road to get into the hospital. Got it.
Pay at the door.
Got it.
Yeah.
Well, I mean, there's actually a question that I don't think is the case in any other system where there's no copay or deductible, I don't think, in any other public system. I don't think, in any other country.
Oh.
And so I would, and I'm me, and all for burying all this stuff, pay your taxes and get your health care and have a nice day. That's sort of me. But, and I guess the data are that deductibles really don't work. Deductibles, at least every time people go and investigate it, including us, people make bad decisions on the basis of their deductible. They stop doing stuff they're not supposed to stop and all kinds of things. But part of me wonders how you stop overuse of people doing, I mean, every other government doesn't seem to worry about that.
Are either of you two aware of any economists or any theories of why sales tax could not be used to fund part of a healthcare system?
The impact of sales tax generally pretty regressive. And so what happens is the poor pay more in the end. And they're deemed to be unfair as a source of revenue. And you'll see the debate going on right now in the Texas state legislature because there are proposals to shift some of the property tax burden over to sales tax, which means that the middle class people who get the exemption on their mortgage interest, the property tax that they pay would be compensated for by poorer people providing more of the revenue. It's just a very harsh trade-off with sales tax.
You'll see it, though, under the guise of the value-added tax. That's what, when you see VAT of people discussing, it's been out there, and there's some fairly hotsy-totsy type people, that's a pediatrician word, that have been in favor of it, despite the craziness of how it certainly does take the bite, to me, out of the wrong people.
But usually, I was thinking in France that the value-added tax was more for yachts and expensive cars.
No, all I'm saying is that it's not, the debate in the United States has not been called sales tax, it's been called value-added tax. That's what it's been under the guise of here.
Because they want to exempt lots of classes of goods that are deemed to be necessary for subsistence living so that people are taxed out of that. But still, the overall effect is regressive.
It's like in Italy, they have a high calorie tax on anything not Italian. What? correct. Yeah.
In the back, yes.
You open yourself, I think you get on a slippery slope when you completely separate, whether you want to call it premiums, deductibles, or copays, any out-of-pocket expense at the time of consumption from the product. Any behavioral economics or any economics 101 tells you, customers respond to incentives, and when you're paying out of pocket, you start associating a value, monetarily at the very least, with that service. And it's kind of, Dr. Garson, what you were getting at. How do you start capping or estimating the skyrocketing of utilization of services when people aren't paying for them every time that they use them?
Well, the problem, and it's what you're saying, what we're all saying makes sense. It's just the data doesn't bear it out in the U.S. that people with, I'm not sure they've looked at it by income level, but that was the original Rand Health experiment from 700 years ago, and no one's able disproven it since, that when you have copays, it doesn't help people choose to do the right thing because they stop doing the wrong thing just as much as they stop doing the right thing.
Yeah, I guess the other thing that I think this opens you up to is it's the black hole, I guess, of government financing. I could pay into this for my individual insurance that's going to, I guess, kick in before Medicare and Medicaid. I don't have faith in the administration of that program, nor the financing, nor the solvency of that. I think the last time I looked, Medicare was expected to be insolvent in 2026. So I don't know how you hold the government who's administrating this program accountable if it's an indefinite year-over-year program and there's no true-up at the end of the year.
When you think about overutilization of healthcare services, first anecdotally, I don't know anybody that goes, oh boy, I get to go to the hospital. I'm going to go 3 or 4 times instead of 1. Or I can't wait to go spend another hour in my doctor's office waiting for my services because this is so much fun.
John, be careful. How about the percentage of people that see the ad on television and walk into their doctor's office ensuring that they have this, and this drug? Be very careful.
Yeah, well,
how about the people that walk in, I've got to have that MRI.
Yeah.
I've got to have that MRI because my Aunt Sarah said I've got to have the MRI. So, and yes, there are plenty of people, I got to have that back operation. So be careful. There's plenty of patient-induced demand out there.
I think if you look at it, there might be a different flip, and that is our compensation system for our providers is based on
no, I'm talking about patients. I'm not talking about providers right
No,
now.
I understand, but I think
patients.
if you look at overutilization, I think there's probably more evidence of provider overutilization.
I don't disagree.
Of services than there is
don't disagree at
individuals.
all, but there's both. The number that
there's
Don
clearly
Berwick says about providers is $200 billion.
Right.
$200 billion a year in provider over treatment. $200 billion. You'd pay for the entire uninsured with $200 billion a year. That's providers. But individual us is like 50 to 70. It's less, but it ain't zero.
Okay.
Next one, Adele. Yes, please.
Agree with that, but then how come all these small European countries are doing it? That's my question.
Doing what?
Providing health care for everybody.
Because the population is smart enough to not want the stupid advertising, to not.
No, I don't think.
And the docs, probably equally importantly, I think there's less data on how much overuse there is in Switzerland or in England. We know in the private system in England, there is lots of overuse, okay? Because there's no boundaries on it. You're in the private system. I'm just talking about Harley Street now. I'm not talking about the private insurance. I'm saying that you can charge whatever you want in the private system in parts of London. But, you know, Luxembourg or whatever, they don't cover stuff. They don't, I don't know whether every one of these countries covers lung transplants. I don't know. I suspect they may not. So I don't know that, but they do less stuff and they charge about a third, right? About 1/3 for doctor visits, about 1/3 for MRIs, maybe some at 7x. So the stuff's less expensive and they do less of it. What I don't know, that's the doctor part. I don't know about patient-induced demand in Luxembourg. Sounds like a great thesis in the summer.
Yes.
I think what you're talking about and what we talked about in other classes is the rationing issue, and how would that have to happen if we went to a universal coverage or to be able to afford our healthcare system. So what are your thoughts on that? And, you know, is it going to be the elders don't get the knee surgeries and the hip replacements, or where do you draw the line?
So and I'm going to turn this back to Stephen in a minute. I'll do this in 30 seconds. If you go look up Zeke Emanuel, who is now at Penn as, I think, the vice dean for whatever, and he's an ethicist. He's an oncologist and he's an ethicist. And he wrote, to me now, the best article on ethics of rationing that I've ever seen. Now, ethics, as you've seen in this course, is tough and it's difficult to deal with. But go look at it. It comes up with a construct very rationally of how you do ration. And yes, the elderly, interestingly to me, to me it doesn't matter as much of how they do it than they attempt to do it, that somebody's finally said. And interestingly, the newborns get the lowest. The newborns now, up to 6, 8, 12, 24 months, they don't get as much. The highest in their construct is adolescents. And, you know, they got all kinds of reasons for it. Old imps like us start to lose, but we don't lose as much as the newborns. The newborns, they say, you can do it again, guys. So anyway, Zeke Emanuel.
He also wrote about a fairly rigid ceiling on the care that would be provided after he turned 70. And then he turned 70 and decided to raise the ceiling.
71.
So just should be higher, I think, now than I thought when I was 62, thinking ahead to what it would be like at 70. So the rationing, if you have universal coverage, the universal coverage is usually for some bundle of services, not unlike the ACA 10 essential services, right? And everyone has access to those services. And then the rationing begins to apply as you move beyond those essential services, what's universally covered. And most of the mixed systems then, the private insurance comes in over and above those essential services, and you begin then purchasing the package of benefits that you believe you'd like to take advantage of. And there's a lot of differential sorting that takes place in that insurance marketing in places like the Netherlands and Germany to some extent.
I think that's the thing that people haven't come to grips with in any of these for all things, is there's going to be intense rationing because we can't afford it all. And unless we're going to reduce the price of health care by overtreatment or something else, if this ever happens, somebody's going to have to say, you can't have stuff. And that's I believe, we've not really considered that as a country because we don't do rationing. And I think that's where this thing is going to come to a screeching halt, is somebody's going to say, well, what do you mean? Medicare pays for everything. Not Medicare for all doesn't pay for everything. And so I think that's where this stuff's going to come to a screeching halt. I want to turn it back to Stephen. I want to do 20 seconds, and I'm not going to say any more for the last 5 minutes. Do not overestimate the power of inertia. I would like to see universal coverage. I'd like to see a single safety net tomorrow morning. There's sort of the big picture of change, which nobody really wants to do it. And if you really look at it, 88% of people have insurance right now. And so do they really want to give that up for something that maybe not? And so I think that this whole notion of let's do all this big change, even though I'd like to see it, me personally, I don't see it for quite some time. Partially the affording, partially the rationing, but partially because is it going to really be better for more people in a future state? I'd like to see that future state, but I think there are a bunch of people that are going to say, wait a minute, I'm sort of okay now. Now, what's not okay is how much it costs. And so maybe the answer is attack cost, but anyway.
Part of the system solutions that you see as you look across different countries is the choice about whether or not you're going to have public financing, a single payer, a global budget, those kinds of financing options to deal with the challenge of universal coverage and to raise the limits on rationing as a way of allocating medical care. You move to the most comprehensive systems include the public provision of care, like the National Health Service in Britain. So public provision of care, public financing of care matching up. And they still permit along the periphery of private insurance markets to govern access to specialist care and people who want to beat the lines and the like. But it's still the case that we have a spectrum of systems that range from both public provision and public finance to public finance, mixed provision to mixed finance, private provision. And we're in a system that has private finance for the most part, as some smattering of public financing and private provision. And so we're really at the end of the spectrum of the reforms that have evolved in other countries to deal with these challenges. So if you think of that in those terms when you're listening to the healthcare reform debates and the efforts to promote by slogan Medicare for all and universal access, begin to ask the questions, many of which you've seen tonight, about what the elements of those programs actually are and about what it means to extend those templates that have problems as they function now in the US, extending those templates to new populations, making them more and more inclusive, or offering them within the exchange markets, not different kinds of markets, but relying on the ACA for the framework, if not the Medicare coverage potential for the whole population. So be thinking in terms of those design parameters as the debate goes on, and ask the questions about what the optimal designs look like as opposed to sticking with what the slogans appear to be dictating. I want to thank you all for coming tonight on our final session. There are evaluation forms on your chairs. If you choose not to fill out one of those tonight, they'll be online, and we'll be emailing to all who had registered for any one of these sessions in the future, and you'll be able to access the evaluation form. If you don't receive one by email, you can access it online, because we'd like to complete the evaluations.
Or we'll fill it in for you.
Yes, that always our
Thank you all.
Thank you very much.